still early enough in October that we can talk about October being Breast Cancer Awareness Month, and we have a surgical oncologist from the University of Missouri Healthcare and in the studio with us to talk about some of the things we need to keep in mind in regard to that. Dr. Debra Koivunen, and I knew I was going to mess that up. Dr. Say it for me again.
Koivunen.
Koivunen. I knew I was going to mess that up. Thank you for your patience with me on that. So as we get to this month again, and people will be thinking of breast cancer awareness, what changes year after year?
I think as the last few years have gone by, we have been able to provide more personalized breast cancer care. A lot of research has culminated in us knowing more about the tumors, and now we are actually able to pattern or design a patient's care based on specific characteristics of her tumor. And so not everybody gets the same treatment anymore.
Are we closer to knowing why some women get breast cancer and others do not?
Well, about 15% of patients with breast cancer will have some familial trend in their relatives, and a smaller percentage of that we can actually find a genetic mutation. The most famous that everybody can relate to is, of course, what happened with Angelina Jolie's mother and breast cancer and ovarian cancer in that family, what Angelina ended up doing to prevent herself from suffering the same fate.
So how long have you been in the field? I'll start with that.
Tough to say. I have been a practicing general surgeon since 1986, first at Penn State and then here. And breast cancer is part of the armamentarium of a general surgeon. But over the years, particularly once I came back here, we've set up our own breast cancer center, and I'm currently the medical director of that.
So what has changed? I was leading up to asking this. What has changed? What have you seen change over the years? Is it our understanding as a society about it? Is it awareness where people get tested earlier? Is it new techniques in helping with the surgery aspect of breast cancer?
A lot of things have changed. I think first and foremost, over the last couple of decades, we've gotten the word out that the earlier your breast cancer is diagnosed, you have the much better you will do with your treatment and may not require quite as much treatment. Then the treatment itself has changed. Surgically, many, many years ago, the only thing we could offer were mastectomies, which is a fairly disfiguring operation. Subsequently, plastic surgery was able to come up with multiple ways to help restore a woman's body image with reconstruction. But the big change that came along is we have figured out you don't need a lot of surgery does not necessarily lead to better care. And so the greater majority of women can actually save their breasts, still get very excellent care for their breast cancer, and live long and fruitful lives.
What are the numbers that you oftentimes see or hear about the percentage of women who may deal with breast cancer sometime during her life?
1 woman out of 8 in the general population is predicted to get breast cancer.
Are you seeing it in younger patients or older patients, or it stays the same?
It's pretty much the same. I think the younger patients stand out in your mind more because you don't expect to see it as often. Breast cancer is most of the time a disease of maturity. Women's risk for getting breast cancer really doesn't start to rise until around age 45 or so.
Are there the after effects of that? I don't know how a doctor who does what you do is aware of what how people are dealing with it after the surgical wounds are gone. Do you understand what I'm asking, I guess?
Yes. We've come a long way in that regard, too. Every person is different and unique, and so how a woman or a man, frankly, men do get breast cancer, deals with the change in their body image, the change that some of the therapy they receive is going to differ from patient to patient. What we have developed, not us particularly, but in the entire field, and we do have it at the University of Missouri, are people called nurse navigators. And these people are specially trained. They will spend extra time with a patient after the physician spends time with them. Be there for them to meet them for particular appointments if the lady needs a little extra moral support. There to answer questions anytime something pops into a patient's head that just can't wait till the next visit with the doctor. And so that has helped smooth the way. We follow our patients for quite a while after we treat them. And so I will see someone 1, 2, maybe 3 years after I've done surgery on them. And a lot of times I'll ask them, if you had it to do over again, would you chosen the same therapy? And amazingly enough, I'd say 99% of them say, yes, I'm glad I did what I did. Once in a while, there is buyer's remorse. Sometimes I can't go back and fix that. But what we try to do is up front, when we're trying to come to a decision as to which fork in the road we're going to take with therapy, really try to impress with the patients that we don't have to make a decision today. This is not a medical emergency. It seems like one, but there are no red lights flashing. There's no sirens going off. And I will most of the time tell them, I'm not going to allow you to make a decision today. I want you to go home and think about it, talk with your family, get a second opinion if you need it, and then come to a decision that you're going to be happy with 20 years down the road.
I've never heard it put that way before. I thank you so much. That makes such sense to me to be able to hear it explained that way. And I was thinking as you started that answer that you do present options to people and that you then give them a chance to think through that. I would guess that maybe dealing with a sense of impatience on the side of the patient would be something that you would have to calm them and say, look, again, this isn't something that you need to make a decision this hour, this day, this week. You've got time.
Exactly.
So what are the options? What do you tell them? I mean, as the options change, I think, over the years, I think it would be interesting to know as you sit down and say, well, here are some of the things you might have to think. I guess each one is individual, and it depends on what the cancer is and where it is and how advanced it is.
Exactly. It can get to be a very complicated decision tree. But for the average patient coming in, they're going to be choosing their surgery first. And so we will, after talking a little bit about what breast cancer is and where the dangers are, if there are going to be dangers as far as shortening their life, we will approach it from the surgical aspect. The first treatment choice is to save the woman's breast, and that's, in common terms, that's called a lumpectomy. And the real formal name is segmental mastectomy, but we tend to not use the big words because they hear mastectomy and their ears shut down. So we say lumpectomy, they know what that means. And with lumpectomy, for the greater majority of women, will require some form of radiation therapy when they're healed from their surgery. And there's a number of choices in that regard when we go down that road. There are other big decision to choose between would be to have a mastectomy, and the greater majority of women are candidates to have the first stage of immediate reconstruction at the time of the mastectomy, so that when they leave the hospital, they're already on their way down the road to getting a new breast. And it combines 3 operations into 2, essentially, if we do it that way. Some women don't want to have a reconstruction. Some women can't, particularly patients who smoke or use any form of nicotine usually are not allowed to undergo immediate reconstruction because of what nicotine does in regards to healing. So they have to be nicotine-free for 6 weeks. But we can do the mastectomy up front and bring them back later for the reconstruction if needed. All of these choices, the lumpectomy and the mastectomy with or without reconstruction, require some form of staging, meaning we need to know, has it gone to a lymph node? In the old days, we would do axillary lymph node dissections, which are not a pleasant operation to undergo. The long-term side effects are not ideal. You can develop swelling of your arm, etc., and some discomfort. So now we do a very, simple approach where we just take 1 or 2 lymph nodes, and it's called a sentinel lymph node biopsy. And by using an injection in the breast before surgery, we can identify what is the first lymph node that drains the breast. The lymph nodes are little glands in the armpit, by the way, and just take that one. And if there's no cancer in it, the assumption is, the assumption is that there will be no other cancer in the lymph nodes. That saves a lot of long-term complications if we can just do that.
I'll let you go in a minute. I'm curious as to if anybody's listening, and right now it might not be that time where they have heard the words breast cancer, but maybe sometimes somebody they know or they may go through that experience. What is your advice then when someone, after having a test, then is called by the doctor or by the doctor's office and say, we need to talk to you, and they know that then they're coming in maybe to hear that we think there may be breast cancer? How do you advise people to immediately react?
Take a big breath, exhale, come in and talk to the doctor. Don't panic, but no matter what I say, there's going to be panic and fear, and that's natural, and I can't make that go away. But the greater majority of women will get through that initial fear response, come in and talk and find out what's going on. And then just have your eyes and ears open. Don't be afraid to ask questions. There is no such thing as a dumb question. I would warn people against jumping online and Googling breast cancer right away. There's a lot of good stuff out there that you can Google, but the problem is without a little guidance up front, you don't know where to begin or when to stop reading, and that gets pretty scary. Usually the doctors will give you some specific websites as well as printed materials, depending on your choice of learning materials, to help you as you move down this journey and start making some decisions.
I think your advice has been terrific today. I hadn't heard a lot of what you've said put exactly the way that you've done that. So I hope you've been very helpful for those who are curious about this and maybe at various stages know that this is something that is impacting their life right now. And your calm demeanor, I think, is very nice for those who are hearing this and maybe aren't facing it now, but maybe somewhere down the road they might. And I hope that something that you've said will click and they'll say, oh, you know what, I heard this. I'm going to react this way. I'm going to ask questions. I'm not going to be shy about doing that. So thank you very much. I appreciate it. That is Dr. Debra Koivunen. Got it. And she is with MU Healthcare, a surgical oncologist talking about breast cancer. This is Breast Cancer Awareness Month, and you're listening to News Talk 1400 KFRU.